is the COVID and dentistry. And let me start with a photograph or the micro photo or enlarged photograph of the what happens when you switch on your ultrasonic scaler, and you see the amount of droplets. It is ejecting something like a cannon fire, and you can see the droplets coming out and the aerosols and the splatter when you work on a pneumatic instrument or a water jet instrument. And this is classically a micrograph or a photograph of what happens when you work with your pneumatic drill or a air polisher or whatever it is, and the dentist goes in and looking very curiously about the quality of the work that he does. So you can note that he is in direct run. This is one of the reasons why I was keen to highlight how dangerous the dentist population in the current pandemic. It is not even in the current pandemic. You can see there are so much of other diseases that can transmit via inhalational route. And we all studied during our postgraduate classes that dental surgeons, one of the occupational diseases for dental surgeons is Mycobacteria tuberculosis. So when tuberculosis was rampant, it is not uncommon to see so many dental surgeons getting infected due to the Mycobacterium TB, and so also the herpes virus infections and Legionella and pneumonia and influenza. These are some of the common diseases that can. That can be transmitted to the dental surgeons through from the patient. So there are some terminologies. These are all infective: the splatter, the aerosols, the fomites, and droplet nuclei. So particles below 50 microns are called aerosols. It is more or less like a colloid. So aerosols travel longer distance, probably up to 6 feet or even longer, or it can contaminate your entire room with the smaller particle which doesn't settle down due to gravity. And particles larger than 50 microns in diameter are called splatter, which are also again travels in a less distant way. And these droplets are the larger visible particles which can travel like a falling trajectory, and it travels probably, they say it's 18 inches or 1.5 feet from the site of production and settle down on the surfaces of your table, of your chair, or whatever, wherever, or on the floor. And these droplet nuclei, which are probably heavier than a splatter and aerosols, can get dried up in due time. And when somebody cleans the room and sweeps, or you switch on the fan, it can get aerosolized and becomes an aerosol. So the droplet nuclei contains, it's larger, it contains more viral load, it contains more of virions, and it dries up and it shrinks, and then it becomes aerosol. So don't think that the splatter or the aerosols that you produce it contains only the irrigant fluid which you use in the tank. From the tank, the irrigant fluids or saliva. It contains saliva. It's a mixture of water, saliva, the blood, that when you cut through the gingival surface of the blood, and the tissue debris. These are all the ones which are teeming with the viruses or the bacteria, and the contribution from the dislodged plaques. So probably this is a mixture of all deadly organisms that you are inhaling unknowingly from day to day. And you and your staff, your persons who are assisting you, including the medical and the non-medical staff. And this is a serious health problem to the dental surgeons and people who are assisting you. And one more thing I would like to tell you is that the virus multiplies in salivary glands, because the salivary glands contain the angiotensin 2, angiotensin converting enzyme 2 receptors. So the virus multiplies in the salivary gland, and it is shed in large amounts in saliva. So saliva is probably one of the most common. That is why it starts spreading when the patient, somebody talks, some infected patients talks. So how can you reduce the viral load within the splatter or the aerosols? You can try pre-procedure mouthwash with povidone, 0.2 percentage or a 1 percentage hydrogen peroxide. This mouthwash should be at a minimum of 20 seconds, or at least preferably a half a minute to 1 minute before the patient spits it out. So ask every patient to do a mouthwash with one of the disinfectant, the virucides. It can significantly reduce the content, the number of the virions within the splatter. And I do not know how far you use high flow evacuation using the procedures. This has to be a high suction device which should suck nothing less than approximately 200 cubic feet of air within 1 minute, and that can significantly reduce your aerosol contamination. And use of rubber dams in procedures like endodontics can significantly reduce the infectivity of the patient, because if the rubber dams are large enough, it can even cover the nose of the patient. I do not know how far it is practical to have all this. So it's coming to the hand washing. You all know that hand washing is very significant in terms of controlling the disease. Both you, your assistant, your patients, the bystanders of the patient coming to the clinic, all should wash hands with soap, because soap destroys the lipid membrane of the viruses and kill the viruses rapidly. So washing with soap, and you all know how to wash with soap. It should be is a generous application of soap or a liquid soap preferably, and you should wash all areas very meticulously for 20 seconds. Not to forget about washing on the dorsum of the fingers, the tip of the fingers, and the inside of the palms, the thumb, and meticulous washing for 20 seconds. And you should teach your patients as well as your staff how significant and how methodically you should wash hands. And you can also use, if you don't have a washing station in your facility, which is to be used by the patients or the sisters or the nurses, you can use, ask them to use sanitizers, hand sanitizers, but it should contain at least 70% of alcohol. Alcohol is a good virucidal agent. And formate disinfection of all your biological waste, you should do it meticulously. You should see that your assistants are doing it as per the standard protocol advised by the authorities. And you can also use UV lamps. This is a very convenient and very economical way of sterilizing your clinic in an overnight. If you can arrange to have UVC, ultraviolet C lights, and switch it on all throughout the night time, and when you come in the morning and switch it off, probably you can have a good amount of virucidal action. And air purifiers, which contains the HEPA filters or high efficient particulate aerosol filters, which has the capacity of around 300 cubic feet of air intake in a minute. You can use, but there is no proof that, but theoretically it should work. And if you have facility in a hospital to use a negative pressure room, probably it is wise to use the negative pressure room in cases where your cases where it is known to produce aerosols and splatter. And this is a telephonic triage of patients before they come to the clinic. When they call for an appointment, ask your receptionist to ask certain details of every patient, because you don't want your clinic to be crowded in the coming months or weeks for with the patients. Now you can postpone the non-urgent consultations, because the government of India has now approved telephonic consultations in the scenario of COVID. You can, your receptionist doesn't ask for fever, cough, or new onset shortness of breath presently or within the past 2 weeks. At the time when they call, you can postpone the elective procedures, reviews, and non-urgent interventions. You can, while the patient, once they had come to the waiting room, your sister can ask about whether they have fever or other symptoms, or take a detailed history and contact details. And that's a golden opportunity to teach your patients the importance of hand washing, use of face masks, and cough etiquettes, and social distancing. This is a sample of a screening questionnaire, which can be administered to the patient while they wait in their waiting area. In the past 14 days, have you or any household member has traveled to endemic areas, had any contact with the non-COVID-19 patients, and any member has exposure of COVID-19 biologic material, and anybody has history of fever in the last 14 years at your home, and symptoms of cough, difficulty in breathing, diarrhea, nausea, or body ache, or loss of smell or loss of taste in the last 2 weeks, and also an assessment about how urgent is the patient's dental condition warrants. Like, do you have an uncontrolled dental pain or infection or swelling or bleeding, which indicates an abscess formation which needs to be drained and which doesn't involve a lot of working with the pneumatic tools. And this is, you should all be knowing about that it is one of the professions, one of the branches of medicine where you need to use absolute complete PPE or personal protective equipment. And there is no way you have to use that, because your profession or your work involves a lot of, direct contact with the patient and direct contact with the aerosols and splatter and droplets emanating from your working tools. And you should use a gown, you should use a mask or respirator, and goggles and gloves, and make sure that your gloves goes over your lower end of your sleeve or cuff. And if you, there has been a lot of or hue and cry about the doctors getting exposed because of the lack of PPEs and masks. You can use locally made gowns or the mask. I'm not very sure how far you can make how the quality is, but you can wear anything. But in case you are wearing a Halloween costume and going to the theater, just call your friends or your colleagues beforehand so that they don't get frightened. And this is one of the goggles that you commonly see, but this again has got loose fitting goggles, but it's preferable to have goggles like this with a rubber shield which prevents the aerosols from entering your eyes. But it's so difficult to work with this thing because it is likely to get fogged with moisture. So just a few words about the mask. You all use the surgical mask, which has typically has got 3 layers, and I'm sure that most of the masks which floods the market right now are probably not of the standard quality. And you have 3 layers, and the outer and the inner layer are non-woven fabric with a high density filter layer in the middle, which is the most important thing. And the outer outer portion of the mask, the tri-layered mask, is water repelling, and the inner one is water absorbing. It absorbs the sweat and the condensate from your breath. So this is the cross section of. So when you select a mask, when you purchase mask, the first thing that you need to do is just open up the mask and see, separate the 3 layers and inspect. Most of the masks, many of the masks I would say available in the market, has got multiple large holes or defects in the central portion, the central layer, which can jeopardize your the protective capacity. And the fit testing, you should tie it very tightly and see whether it's snugly and comfortably and fits your nose, and the air doesn't leak out while you cough or speak out. And the third is a leak test, which you can do is just invert the outer surface, pour some water over the outer layer, and see whether the water is leaking. If the water is leaking too much, the mask is defective or it is not a good quality mask. So you can also put the water on the other side, the inner side, that is the side which faces your nose, and see whether it really absorbs enough of water too. And one of the other things which you can do is you can just tie your mask and keep a lit candle most 15 to 20 centimeters away and try to blow up the candle. If you can try to blow the candle with ordinary efforts, then that mask is not good, probably of inferior quality. And the mask, especially the central layer, should not catch fire. It can burn, it can melt down, but it should not catch fire. So those are the qualities of selection of mask, the tri-layered mask. So it's better that you use an N95 mask, which the characteristic of an N95 mask is a melt-blown cloth, which is one of the layers which prevents filtration of the smaller particles. That prevents N95 means it prevents, it filters 95% of the particles or the less than 0.25 microns. So it's better that you use N95 mask of good quality or reputed quality if it's available. So these are my take-home messages. I know that I have exceeded time and probably caused hypoglycemia in at least some individuals, because it has exceeded the dinner time for many. And as far as possible, avoid aerosol generating procedure within your clinic. So that's the gold standard. You can also postpone non-urgent clinical procedures to a later date, or you can adopt a non-surgical management of the current problem if it's not a severe problem. And use, as far as possible, use extra oral X-rays with cone beam X-rays or general X-rays. It's better that you avoid intraoral X-rays, which can produce a lot of gag reflex and aerosol generation, and you are at the risk of getting infected. So at this present time, as far as possible, you use external X-rays. And you can use a 0.23% povidone iodine or hydrogen peroxide pre-procedural mouthwash, as I discussed. And use, as far as possible, disposable instruments. I do not know how far that is practical in a setup like in developing country like India. And use of rubber dams and high volume evacuation instruments are highly recommended. And it is mandatory to take the contact details of the patient. The current details of the patient must have come from another state or country or another district, but you should take the exact contact details of the patient, and this is for reporting purposes and contact tracing. You should ask your assistant or your receptionist to take a detailed history, especially about the travel or somebody in the house with symptoms. And it is mandatory to record fever, but most of the cases with dental infections, the patient will run fever. Now you can't rely on fever, absolutely state that this patient has got a suspected corona or not. And take care, enough care, and see to it that the disinfection of the surfaces and biowaste are done in a proper recommended way. And people say that you should avoid ibuprofen because there has been a series of, there's been an increased mortality of sick patients who are taken ibuprofen for fever control instead of paracetamol or acetaminophen. I do not know how far it is safe to use the other NSAIDs like diclofenac or aceclofenac. I don't know. I'm not aware about that. And as I always say, avoid indiscriminate use of antibiotics, and polypharmacy, use of multiple antibiotics and use of unnecessarily antibiotics. I think by and large, if you have a patient with a collection of pus, just let out the pus and the patient doesn't have so much of surrounding inflammation or infection. And just wait and watch unless the patient has signs and symptoms of systemic infection like fever or chills or something like indicates bacteremia or viremia. So as far as possible, avoid antibiotics, and if at all you are using antibiotics, use the right dosage, the right interval, and according to the weight of the patient. Tablets are manufactured in different strengths because they can't have tablets manufactured in 10 strengths, but you can use the antibiotics, the common antibiotics that you use as per the weight adjusted dosing. And we are entering into the end of the lecture, and we are also entering into the different different culture or different I would say different era of doctor-patient relationships. And we will not have the so-called comforting, reassuring handshakes, or which you call the physician's left hand, which is a reassuring hand, which we always seek out for the shoulder of the patient and reassuring just a pat. So we are not going to have no more handshakes, and we would resort to namastes, and we would always see patients like this. Where patients will, mostly come with the majority of their facial features covered, and all you need sometimes, you have to identify the patient is just looking at the eyes, and all the patient also sees the apprehensive doctor in goggles and protective equipments and things like that. So it's no longer going to be, the outpatient clinics are no longer going to be so much warm and comforting and probably intimate as it used to be. And doctors in the patients in the intensive care units probably sees doctors as zombies, something like this. And they do not know whether Dr. X or Dr. Y is in that particular suit. Or now this is going to create a lot of unrest and panic within the patients admitted in the emergency units and inside the hospitals. But we have no other way than doing this, because one of the prime importance is to protect the healthcare workers. You and your staff and your assistants is of primary importance, because in a war or in a battle, if you don't have soldiers, frontline soldiers to combat, you are going to lose the battle. So it's very mandatory to protect your healthcare workers. Especially, I would suggest that people, doctors, practicing dentists over 70 years, has to really, really worry about getting infected, because once you get infected, it is going to run a very bad course. I do not know how far it is going to behave in our part of the world. But as far as the Western lessons teach us that above the age of 70, the disease behaves very nastily. And this, I would say, is the future of dentistry, is dental robots, just like the robots engulfs every other, it engulfs every other walks of surgery. And you're also going to have dental robots or dent boards, where you can do the procedure sitting in the next room or after a class partition, or even if you have a fast speed internet or a Wi-Fi, you can do it, the procedures sitting in your home. This is another kind of work from home. So with this slide, I would like to wind up the session. And thank you very much for your patient listening. And I know that I beg your apologies and pardon for taking so much of time in the fine evening. Thank you so much, and take care and stay safe. So, moderator, please.
Dr. Ravi, can we have a few questions from the audience? I think they are typing out few questions in the chat.
Yes,
Maybe.
I can.
Role of pulse oximeter. Role of pulse oximeter.
Pulse oximeter. Okay.
Yeah, there are a lot of newspaper reports about the role of pulse oximetry. How far is it reliable?
Maybe my answer is maybe in the hospital settings where patients are coming with respiratory infections. To categorize the patient, pulse oximetry is essential and probably a valuable tool. But in patients who do not have the symptoms, I don't think it has got any role in saying that somebody has got the corona infection or a disease or doesn't have. Yeah, of course, if the patient comes with the cough, the new onset cough, or the worsening of the recent onset breathlessness, probably a low saturation means you can contact the primary care physician, or you can ask the patient to immediately seek medical attention. Apart from that, and distinguishing patients who are infected or not infected, pulse oximetry. Okay. Hope I made it clear.
Dr.
Yes.
Varghese, this is Dr. Sam.
Yeah, tell me, doctor. Hi.
Just this, as mentioned about pulse oximetry, because it has been reported from news today coming from the ICMR also, saying that there is a lot of instances of silent hypoxia.
Okay.
And what is that in relation with COVID?
Yes. That's a very interesting thing with COVID, because patients, patients do tolerate hypoxemia to a great extent when they have COVID, because I told you the lung involvement is not very typical of that due to other infections, because we see basically two kinds of lung infections when it comes to a critical stage. One group of lung disease shows all characteristic features as that of any other ARDS, where the lungs are very stiff, very difficult to ventilate, and patients, going into. But once you start ventilating to the patient, oxygenation shoots up. The second group are those patients whose lungs are not stiff. They are. It is easy to ventilate them, but the oxygenation doesn't come up. So there is a heterogeneity or non-uniformity in the presentation of COVID cases in the places where the patients shower in. Patients, crowd. There are pandemics happening, like in New York or Italy. So silent hypoxemia, of course. That is one of the reasons why you can justify using a pulse oximeter. I do agree.
So probably having the infrared thermometer and the portable pulse oximeter would be advisable.
Yes. That is probably advisable. But my impression is that you have to take care of every patient as if they have corona infection. One of the golden dictums that happens in surgery is that if you do surgery and fear about HIV or hepatitis B, you cannot say that which patient on the table in an emergency setting coming with trauma or any other catastrophic event is going to have HIV or hepatitis B. So the golden rule is that treat every patient as having HIV, or you take universal precautions. So I think just by looking at the saturation and fever temperature, we should not have a false sense of security that personal protection equipments and personal measures are not important.
Hello, sir. So
Hi.
this is Akhilesh. There are a few questions from the audience. I'll
Okay.
just read it out one by one. Would you be able to answer them, like,
yeah,
if you have time permits?
enough of time. Okay.
Yeah, okay. So one of the questions is, can we check temperature with thermometer? Probably they mean the mercury thermometer.
Okay. Can we check temperature? So in a community setting or in a clinic setting, it is not possible to have a mercury thermometer, checking all the temperature. It is better to have infrared thermometer. It's available, not that very expensive, less than 1,000 rupee. You can get infrared thermometer. You don't need to touch the patient, just show it and switch it on. It will read the skin temperature in the forehead. So that is better. So and second thing is that mercury thermometers are no longer available because mercury is a poison. It contaminates the environment. So mercury thermometers are now difficult to get. You get only the digital thermometers. You can use.
Basically, you have to use a non-contact thermometer.
Yes, exactly,
So,
exactly.
Now, another question is, now there are a lot of appreciation for this one. So it's for your class. It's a wonderful lecture, great presentation, sir.
Thank you very much.
So another question, can surface disinfectant be used on the outer surface of N95 mask so that it may be reused?
Okay. All right. Good question. See, for all practical purposes, the outer surface of the N95 or a three-layered mask is considered to be contagious. It has already been contaminated. You can presume that every mask you use, the outer surface is contaminated with corona. Just think about that. So may be a COVID patient or a COVID, whatever it is. You just think that the outer surface is contaminated, and you should not touch the outer surface. So what you can do is, when you have a shortage of this N95 or N95 mask, you can reuse it. But what you need to do is, you better have three numbers of N95 mask, label it. You start using that first on day one, and after use, you keep it carefully, fold it by the inside goes inside, fold it and keep it in a plastic container, label it as day one. And then you use the second one on day two, and the third one on day three. You preserve all these masks, and then start using, on the fourth day, you start using the first one, because it is stated that the virus doesn't last, with all good hopes, the virus doesn't last on the surfaces for more than 48 hours. There has been some innovations which has been found out. One of the innovations which came from somewhere, I saw it in WhatsApp, is that you can use one of these non-functioning small refrigerators, fix ultraviolet rays on UV lights on the top, and you can keep the mask, or your mask, and all masks will be labeled as whose mask is this. You can keep your mask, your clinic staff's mask, your assistant mask, everything inside, and keep it on. Keep the ultraviolet light on for overnight, and you can sterilize it. That is that is one of the methods, by which you can. But if you don't have such a facility, try to use 3 numbers of masks for every doctor or every assistant. You can. It is not known, whether you can just spray some disinfectant, because most of these disinfectants are corrosives too, and that can corrode or that can damage the layers of the mask. So it is not advisable.
Could we just use a 3-layered mask over the N95 mask and then dispose it and reuse the N95?
That is one of the alternatives. That is one of the you can use a that is one of the alternatives. When you have shortage of the N95 masks, that is one of the alternatives. But still, you consider that the outer surface of the N95 mask to be infected, contaminated.
And most of the dental clinics, they do have these compact UV sterilizers already. They use it for storing their sterilized instruments. Actually, they are used for storage rather than sterilization. But most of the dental clinics have them.
Very good to know that. That could be one of the best ways of keeping, sterilizing your things which are to be reused.
Okay.
But make sure that all surfaces gets the UV exposure. Make sure that all surfaces of the mask you get UV exposure.
Okay, all surfaces should get UV. So now another doubt I have is is it adequate if you use just the shield and does the COVID spread through coronavirus spread through intact skin?
We do not know right now. At present, my answer is we do not know right now whether the corona can. But if you look at the similar coronavirus infections in SARS and Middle East respiratory syndrome, the answer is no. So far, there is no evidence that this can pierce the normal skin. But if you, of course, if you have some cuts or raw surfaces, probably the virus goes inside. Because for the virus to get entry into the cells, need a receptor where the virus attaches and pushes its the nucleic acid into the cell. So the skin doesn't have these receptors. The simple
skin doesn't have these receptors. So the reason for asking this is, can we get away with by just using an N95 mask and a shield? And probably wash hands after, wear gloves of course, and then wash hands after every procedure till elbows or something.
Yeah, the thing is, you can have your splatter in your clothes, your body. Even if you have a naked portion of the neck exposed, you can have it over that. And it is very interestingly, it is stated that on an average, every person touches their face 23 times in an hour. So if you happen to touch any other part of your body or even your dress, and then with that, you unknowingly touch your face, especially the nose. I mean the nose. You can have a infection of the virus. So as far as possible, try to use a personal protective equipment because your procedures mostly are generating a lot of aerosols, which you are going to soil your clothes or your skin, which can be indirectly or inadvertently be carried on to your nose or mouth, by which you can get infected. So as far as possible, try to use
the full PPE kit.
PP while using while you use some aerosol generating procedures.
Okay. And there is another question that's from Dr. Piyush Dua. By autoclave, can we reuse the N95 mask?
No.
We are not supposed to autoclave it, right?
No. It will get the portion, the fourth layer, the melt blown portion will get damaged. You cannot use autoclaves. It is going to damage. You cannot use.
Another question from
and etio gas too. You cannot use etio gas too.
You cannot use ethylene oxide. EO2, you cannot use
that is a consensus. Yeah.
Okay. And another question from Dr. Samuel Kenainen is, up to how far from the UV light source does the disinfection work?
No, I cannot. I'm sorry that I cannot quantify the percentage of sterility offered by the UV mask. But what happens with the UVC spectrum damages the viral genome. It splits breaks the viral genome. That is how it works. So how far the second thing is that we need to have viral cultures of the instruments or the reusable things that are being UV sterilized, and we need to have viral cultures done on that to say that that much percentage of the viral sterilization happens with UV light. But just like any other RNA viruses, this is also going to sterilize. The UVC light is also, there is no reason to believe that it doesn't sterilize. But it depends on how far the surface is exposed to the source of the UV light.
So can you comment on fumigation of the operatory?
Yeah, you
is
can.
Is it important, or it can be done away with it? Or?
Yeah, you can comment.
No, could you comment anything on the fumigation?
Okay. Fumigation is a standard protocol. Even otherwise, you can use a fumigation. So it's better that you fumigate every day using formalin or some tablets or some kind of thing that probably helps in preventing the droplet aerosols and the fomite transmission. You can try.
Actually, the question was asked because almost 100% of the major operation theaters use fumigation, maybe twice a week or maybe every once a week at least. Okay. But dental surgery, dental operating rooms, we are not all at least have started fumigating this thing. So that is why a question about the relevance, whether it is useful or it's just a.
Fumigation. It is good strategy to film, but I haven't seen the overimportance or emphasis of fumigation in any of the articles which I went through. Of course, it is definitely, but is it possible that you can have this fumigation done on everyday basis? I do not know. I'm very skeptical about it, because once you come in the morning, you'll be exposed to the fumes and things like that. It takes time for everything to go out, and it's probably a cumbersome procedure to fumigate every day. But I do not know exactly.
Yes, fumigation by formaldehyde, it's definitely not an option. But I think fogging. There are some machines, fogger machines, which are available, good, which uses hydrogen peroxide. Okay, so that can be done every day.
Okay. Quaternary ammonium compounds also good.
Okay, sir. And so 1 or 2 questions more.
Yeah.
So there is another question, sir. If the incubation period of the virus is 14 days, how come the new cases are reported after a period of 28 days?
Okay, that's a good question. We have had. So what I'm trying to say is, the incubation period is 14 days. It's an arbitrary thing. It is taken as an average incubation period. But we have had cases reported after even 23 days or 30 days. But we do not know whether this is a real incubation period or that particular patient had got a disease from another unknown source. We are not very sure whether primary index case, the R0 patient within the family or within the community is the real source of transmission for that particular individual. It could be another person. It could be another person, an unknown healthy individual. So on a quarantine basis, or it is not practical to have somebody in home quarantine for more than a couple of weeks. By and large, 99% of those individuals show the signs of the infection by 14th day.
So there's one more question, and is the disinfection and reuse of PP advisable?
That's a difficult. All PPEs are made for single use. But if you can use it for multiple times is a question to be individualized. How far it is it can be used, or is it really resistant to the measures that we use? Because many of these disinfectants can cause structural damage to the. It is designed to be used on a single use and throwaway basis. But when time comes, I would say that something is better than nothing. I would say that we should reuse when in short supply, and it's not practical to have PPEs done for every patient. I think we should reuse. Something is better than nothing.
So we are coming to the end of the session. Just 1 or 2 questions more. Could you just comment on herd immunity, your opinion on herd immunity and viral load?
Okay, the herd immunity is that when a pandemic happens, the pandemic happens, we can presume that all the individuals in the community are naive or has never come across such a virus, and they have zero immunity. They don't have any immunity to that particular virus. So they are susceptible, 100% of the population are susceptible to the infection by the virus. That is the basic presumption. But as the infection grows in the community, that is the community spread happens, many of the individuals inside the community will get a subclinical infection, or which may not be a symptom, something like a vaccination. When the viral load is low, especially the viral load is low, some of these procedures, especially these procedures, have got a high viral load transmission, but the viral load is low. The individuals can have subclinical information. They just goes. So likewise, when 60 to 70% of the community are infected and shows sufficient degree of antibodies determined by quantitative analysis of their serum in epidemiological surveys at random community studies, then we can say that there is a herd immunity. And that's the time when the pandemic curve comes down, because that's the time when the R naught, or the infectivity from a single patient comes less than 1. So that's the time when it falls. So that was one of the ideas which United Kingdom adopted. They didn't do so much of testing like other countries did. They presumed, the NHS presumed that this disease is invariably going to get spread in the community among the doctors, the health workers, and some of them get sick. We'll admit the sick, we'll treat the sick. And when the herd immunity happens, probably by 2021 spring, that's the time when they expect the 60 to 70% of the community getting infected. And that's the time when it falls down. So it's better to look for herd immunity, and it is probably futile, or it is not worthwhile in isolating, testing, etc., etc. But that strategy, they quickly realize that the things are getting out of control. The hospitals are crowding. It is going to, they didn't have ventilators. All of the United Kingdom had probably less than 5,000 ventilators. So they started searching panicky for ventilators, because the cases were crowding inside the hospitals and people were dying. And that's the time they changed the strategy to stricter measures like quarantine and testing and things like that. So herd immunity is the ultimate thing. That decides whether the infection is going to have control. And herd immunity can also be attained using use of vaccines. So if you have a vaccine, if you have a very efficacious vaccine, and which can be administered to the large masses, then probably we can have a herd immunity by vaccination too. Hope that I have made it clear.
Yes, sir. Thank you. So the second part of the question was about viral load.
Okay, it is not definitely proven that the number of virions in an infective piece of aerosol or fomite is going to cause a severe disease or not. This is a controversial area. Still, we had some discussion happened on this regard, but so far this is a controversial area. I don't have any comments on that. But people say that why doctors get sick, and especially some specialties, especially orthopedicians, get sick because they are getting exposed to a lot of aerosols which contains larger particles and high viral load. So it is to be seen, to the best of my knowledge. There are
so most of us have stopped practicing right now, and we are planning to go back into practice in a short while. Now the question which has come from Savia Sajid is that, is there any difference between air-conditioned room and non-AC room in spread of virus in the dental room? Can we use the air conditioner while working, or we should work with the non-AC?
You can use.
We can use.
You can use your air conditioners, provided You have a facility to change your air within your inside of the room at least 6 times an hour. So that means one of the disadvantages of having a split air conditioner, which we all have split air conditioners, but we do not have window air conditioners available right now, is that we do not have facility to entrain fresh air, and we do not have any option. Once the room is shut and the split AC is switched on, the whole air is recirculated. So probably you should have, if you are using an air conditioner, you should have facilities to exit air. So one of the things which you can do is to make a hole in the side wall away from you, and use fit an exhaust fan, but your AC will not be practically working because the exhaust fan pumps in more cold air than what the air conditioner pumps in. So, but still, it's one of the strategies. But coming are the days when we really, think we should think about having air conditioners or not.
So there is another request for, I think we'll conclude with this thing. There's a request for explaining negative pressure room. Is it required, or is it practical in dentistry as far as dentistry is concerned, or is it just for?
Fitting an exhaust itself is a negative pressure room. You can fix an exhaust and make your pressure, make your clinic a negative pressure room, because what the negative pressure says that the air from your room should not percolate into the patient waiting area or reception area, or where people sit and can have the air, the contaminated air to get inhaled. So fixing a exhaust fan itself will make your room a negative pressure room. You don't need to go for high gadgets. So all that you need to do is put some smoke. Just close your entrance of your procedure room, switch on the exhaust fan, and show some smoke outside the bottom of the door, and see whether the smoke is sucked into your procedure room. That means your room is negative pressure. It is not going to, your contaminated air from your procedure room is going to go out and contaminate the other parts of your clinic or building or patient waiting area. It's as simple as that.
Okay.
Actually, sir, can I have a question?
Yeah, sure. Please go ahead, Ravi.
Sir, actually, we have heard that by May 3rd, the lockdown is just getting loosened up. So we might have many people coming out to the community or traveling around. So will it be feasible to start a practice after the lockdown settles? A dental practice after the lockdown has been loosened. That is after May 3rd. Is it good to start a full-fledged practice from May 3rd?
I still believe that dentists are an essential part of the medical community, and we cannot just run away from the reality that we need to practice, we need to look after our patients. Our patients' health is the prime priority. We should start resuming our practice, but the prime priority is the consultants or the doctor's health and the health of your person, your assisting persons, be it doctors or nurses. That is prime priority. One of the golden rules is that there is no emergency in pandemic. If you see a patient coming in pandemic with bleeding, your PPE, your health, your protection comes foremost. You have to protect yourself first and then attend to the patient. It's something like, when you get into an aircraft, the announcement comes, in case of a drop in air pressure, your oxygen mask will drop down. And if you are seated next to your kid, first wear your face mask and then attend your kid. The same applies true in medical practice and surgical practice too. Your health is priority. You need to be healthy because many patients want you. So in a case of emergency, your protection, your personal protection equipment, your mask, your goggles, everything comes in first. But we can't run away from the reality that we are not going to stop our practice for the next 12 months or so, when the vaccine is going to come and herd immunity comes by natural or vaccination way, whichever. So I think,
Doctor, one more.
I think we can.
One more last question, Dr. Simon.
Yeah.
After a patient is cured of COVID, is there any chance of getting COVID again? If so, why?
good question. Good question. We thought that once out of COVID, you are immune to it. But there has been reports coming from many parts of the world that patients who have had virus positive initially, turning negative, at least on 2 occasions, the patient has become negative, and the antibody levels were tested. The serology says they are positive antibodies, but after a few weeks, they still turn out to be viral positive. We are not very sure what level. Does it really confers an immunity? If so, what level of antibody titer within the individual is going to confer the immunity? See, I can say that we are just innocent, small children picking pebbles on the seashore when the whole, in the amidst of the pandemic, we do not know so much about the virus and its behavior, whether it's going to alter its outer coverings, whether it's going to give a long-lasting immunity. Because influenza virus, you know that it changes its envelope every now and then, and that's the time when you need to vaccinate every year for influenza, annual influenza. So right now we are not very sure whether infection can confer long-lasting protective level of immunity. Okay, there's a question, Dr. Thomas from New York. Barrier techniques, covering chairs, headrest, disposable tube coverings are effective also. We use glutaraldehyde here, and also rinsing with 12.12% chlorhexidine gluconate before the procedure is also recommended. These are suggestions. Thank you, Dr. Thomas from New York. He says barrier techniques, they're covering chairs, headrest, disposable tube coverings, and they use glutaraldehyde for formaldehyde disinfection as well as cleaning the surfaces, and also rinsing with 0.12% chlorhexidine gluconate before the procedure. Thank you. This is just a comment.
So if there are no further questions,
there is a question by Dr. Namrata. Is it plasma therapy working? It should work. Theoretically, it should work. But again, the question is, we do not know what is the protective level of immunity offered by a passive transfer of humoral immunity, that is plasma transfer. You are transferring passive immunity. So, but there are studies which very robust studies, though done in a small cohort of patients who went into the ventilator, that it really works. The only thing is that you have to administer much early, because what happens, most of the patients die due to corona infection is the aftermath of the viremia. So the virus dies out, and the virus has switched on certain immune mechanisms. So the best thing is that when you have a patient becoming bad, start it early. It should work, and it is working in small cohort, very convincing, very robust studies. Thank you.